All right, guys. Just thank you for that introduction, Leo. Again, I practiced as a medical science liaison for the last couple of years, and I am working in the field of the psychiatric therapeutic area. I do want to talk about a few limitations before I get started, which is that I'm not a specialist in addiction and I don't work in pain management, but I do consider myself something of an expert on deciphering clinical trials, presenting them to physicians, and really that's what I do. So I really enjoyed looking at the clinical studies that were funded by MAPS in Ibogaine, and these are going to be a little bit different from what I usually look at. Usually it's phase 2 through 4 human trials, and these are going to be observational studies in humans for Ibogaine. And what is Ibogaine? You may be asking. It's certainly a lesser known psychedelic medication, but Ibogaine is notable for its anti-addictive properties, and specifically for its ability to negate physical dependency of opiates, although there actually is a trial ongoing looking at its use in alcohol withdrawal as well. So we'll go ahead and get started, but you might be wondering, why don't I know about Ibogaine? We have an epidemic in America, which is for opiate use, and apparently there's this medication that can, help us attenuate withdrawal. Well, as we're going to find out, there are both virtues and vices for Ibogaine, and I consider it a very interesting molecular entity. On the left-hand side of the slide, you'll see a picture of the Ibogaine or Iboga plant. It's a shrub native to West Africa, and it was used by the Punu and Mitsogo peoples of Gabon. They used it as a rite of passage for young men at their time of coming of age. And they also used it in lower doses to help suppress hunger and thirst. And only more recently has it really been used for psychedelic exploration. Now, it is one of the more difficult trips one could have. It causes nausea, vomiting. It's a very long trip, and we'll get to why that is. It can last up to 2 days. So it's certainly a more difficult trip. In the center of the slide here, you'll see the structure of Ibogaine as a molecule. It is an indole alkaloid with broad pharmacologic spectrum. And I want to talk about some of the receptors that it agonizes in case you're familiar with this. It's known, and this is just what it's known to agonize, but it agonizes the NMDA receptor, 2 types of opiate receptors, both mu and kappa. It hits that infamous 5-HT2A receptor subtype, which may be mostly responsible for its psychedelic features, also hits nicotinic receptors. It does have an active metabolite, which is noribogaine, and Ibogaine has a half-life of 28 to 49 hours, which is why it's such a long trip. On the lower right-hand side of the slide is 18-MC, which is an Ibogaine derivative, and it's really beyond the scope of the presentation to talk too much about it, but this is something that has also shown to be effective in animal models for helping to decrease opioid dependence. And it's not psychoactive, and it has a broader therapeutic index, meaning it may be safer at the doses that it's given. So we'll talk a little bit more about 18-MC at the end of the presentation. No presentation would really be complete on Ibogaine without at least mentioning Howard Lotsof. Howard Lotsof was a young man in the 1960s who was addicted to heroin. He lived in New Jersey and had a chemist friend who gave him some capsules of Ibogaine and was said, this will really trip you out type of thing. So he took these capsules and he went on a 2-day trip. And when he was finished, kind of as in his words, wandering the streets of New Jersey, he found that it was the first time that he could remember that he no longer had a craving for heroin and he had undergone no symptoms of withdrawal. So he gave a few capsules to friends of his, 6 friends in total, and 4 of those 6 friends also had similar experiences that they were no longer craving heroin once they had taken it. He then decided to make it his life's mission to bring Ibogaine to the West. Now, there are about 80 Ibogaine clinics that operate worldwide. Therapy costs around $3,000 to $15,000, and what they do at these clinics really varies quite widely. The safety precautions they take and that type of thing. It's estimated that about 15,000 patients have undergone Ibogaine therapy. Now, I do want to talk about the type of trip that Ibogaine will put one on. Now, I'm going to refer to it as a psychedelic trip throughout the presentation, but it's more specifically been described as onophrenia. So I want to make sure I say that right, which is really more like a dreamlike state versus that of a psychedelic-like state that one might be more familiar with. Again, this experience can last 24 hours or longer. It can be with or without visual or auditory hallucinations. It often comes with a dissociative experience. And what's really unique, I think, to Ibogaine is that it's commonly reported to induce psychological insights regarding emotional biographical events. So you may revisit a time in which you lost a loved one. You may have a conversation that you never actually had with that person. And people often think that this is what allows the attenuation of opiate usage. We'll talk a little bit more about that in a minute as well. Now, you might be saying, why haven't I heard of Ibogaine? The voices have risen about that. Why don't we know about this? Well, because we know that there's 135 people die of opiate overdose every single day in the US. So why don't we have this here? Why is it a Schedule I substance? Well, Ibogaine does have some pretty significant safety concerns. It is known to be cardiotoxic, and that mechanism happens through QT interval prolongation. So the QT interval is the normal part of the sinus rhythm. If a medication prolongs this, you can have bradycardia, which means a lower heart rate. And then if it gets severe, it can actually induce fatal arrhythmias such as VTAC or VFib or even torsades. Ibogaine might also be neurotoxic, although there's less evidence for that. It's thought to be more toxic in females than males, and 33 deaths have been reported for patients who have taken Ibogaine. So it's certainly something that's going to be important, and we'll be talking about that more in the presentation, some of the safety findings that we found. So that's really the background on Ibogaine. So now we're going to kind of move into the meat of the presentation. And to date, there have only been 2 prospective studies of Ibogaine. Everything else is essentially anecdotal reports. And both of these studies were sponsored by MAPS as observational, non-interventional, non-placebo-controlled studies. Study 1, which I'll refer to as either the Mexico study or may call it Study 1, was published by Brown et al. In the American Journal of Drug and Alcohol Abuse in 2017. And Study 2 was published by Noller et al. In the same journal at the same year. Both of these had very similar inclusion-exclusion criteria, and really the trials were quite similar other than their locations. Inclusion criteria: all patients had to have opiate use disorder. They had to have a reliable method of communication and be willing to follow up with investigators for at least 12 months. And all patients had a clinic stay of 3 to 6 days in which they were given Ibogaine. Exclusion criteria included a few factors, such as prior treatment with Ibogaine, or if the investigator thought for any reason they wouldn't be able to follow up. So we won't get into the nitty-gritty of the treatment protocol for either of the studies. Just know that these clinics did do some background medical tests. I think most importantly, they took an EKG to see if the patient had an unusual QT interval. And what I should have mentioned on the previous slide is that one of the most commonly used medications to detox opiate patients, which is methadone, also has QT prolongation. And so these can have additive effects. So if one is on Ibogaine, they're on methadone, and maybe they're unhealthy otherwise, these patients are more likely to get in serious trouble. So patients were then stabilized before taking Ibogaine onto short-acting opioids. Most patients were in a range of 90 to 270 milligrams of oxycodone, so pretty serious doses of opiates before they started. And then patients were administered 1,500 milligrams of Ibogaine on average, although this varied widely, plus or minus 920 milligrams. And this was entirely on the practitioner's preference, and there was no treatment protocol in these studies. They were given it, and this seems to be quite common for Ibogaine sessions. They were given this first as a test dose of 3 mg per kg. Then they were given a flood dose at 4 times higher than the test dose. And then finally, the practitioner gave booster doses as they saw fit. Let's talk about some of the baseline characteristics of the first study. There was a total of 30 patients, majority male, average age around 30 years of age. Patients were most often in this study on IV heroin, and also most patients took more than 1 opiate, 2 on average, although some patients vary between 1 and 3 opiates. Patients had long-standing opiate use of an average of 5.2 years. So let's talk about the primary endpoint of the Mexico study. Now, the results won't be on this slide. I always think it's important to talk about the scales that are used in a clinical study. So you're not just looking at numbers, you kind of know what we're looking at here. And the primary endpoint of the Mexico study, as well as the New Zealand study, was the Addiction Severity Index, or ASI. And what this really looks at is multiple psychosocial metrics, including probably the most important for us is drug use, but it also looks at if the patient's in legal trouble, is having family trouble, if the patient's able to be employed, so on and so forth. These questions account only for the 30 days previous, and patients were followed up at 1, 3, 6, 9, and 12 months. So we'll see a number of results on the next slide. Scoring is counted from 0 to 1. And so if you have a score of 0, you have essentially no problems in that particular psychosocial area. If you have a score of around 3, it's probably time to get treated. If you have a score of, like, I would say 5 or higher, you have a very severe problem. Okay, so let's take a look at the results of the Mexico study in terms of ASI scores. And before we look at the highlighted sections, I do want to draw your attention to the upper left-hand side of the chart. You'll see an N there. You'll see, if you take your eyes across the right, at pre-treatment, we have all 30 patients involved in scoring. However, by the time you get to 12 months, we're down to 14 patients who are still following up with the researchers. So we did have a drop-off in patients. That's quite common for these type of trials, especially when they're observational and not on site. So looking at drug use as the first highlight, we see that patients have a score of 0.4 on average, meaning they need treatment, essentially. And then at month 12, this has dropped for those patients who are still responding to 0.17, and a lot of variability in there, 0.17 plus or minus 0.1. This is a statistically significant drop for those patients who did follow up at 12 months, and I would say almost certainly clinically meaningful. 0.17 means, you might need treatment, but you don't need it immediately. In terms of family and social status, the next highlighted row, patients started at 0.24 and dropped all the way to 0.04 at 12 months. Again, somewhere in the range of needing help to being almost normal, or really in a good place. And then I'll bring you to the third highlighted row, which is opioid-free days in the previous 30. So at baseline, patients were using opiates 29 out of 30 days each month. At the end of the study, for the 14 patients who followed up at 12 months, this was decreased by 17 days out of 30. So they were down to using opiates only 13 out of 30 days. And some patients weren't using opiates at all. So again, clinically meaningful, especially for those patients who had complete cessation. I do want to note that an important caveat to these results are that they are self-reported via telephone interviews. So, you do have to take them with something of a grain of salt, but I do think that they are definitely encouraging. The authors of the study also wanted to see whether the psychedelic component of Ibogaine was important to lowering the amount of opioid use. So they gave something called a States of Consciousness questionnaire, which has been used in other psychedelic studies. And if patients had a score of 6 or 7, then they can be thought to have had a strong psychedelic experience. And surely enough, patients who had a strong psychedelic experience were actually using less opiates at the 1-month time frame. And this was statistically significant with a p-value of 0.028. Now, I want to have a little discussion here because I think there's 2 camps on Ibogaine and really kind of 2 camps in the psychedelic community. Some think that the psychedelic experience is necessary for whatever they're trying to accomplish, such as opiate withdrawal attenuation. And there's others that think, these are drugs just like any other drug, just like a blood pressure drug, and you hit the right receptors and the right combination, and that's the effect that it has. You just use opiates less. I probably tend to be in the latter group. I think it's more pharmacologically induced. And although this is evidence against what I'm kind of saying, I will think back to 18-MC, which is an Ibogaine derivative, which shows in animal models it's able to lower addiction to opiates, and it doesn't have a psychedelic experience. So there's evidence on both sides. I think everyone gets to have their own opinion on that. So next, we're going to talk about the SOS score. And if you think of the ASI as like a long-term outcome out to 12 months, you can think of SOS as a very short-term outcome. It's really the patient's experience of withdrawal as it happens. So in that first 72 hours or so. The SOS score, SOS scale, asks questions like, do your bones ache? Do you feel like vomiting? Are your muscles twitching? And so it's a scale from 0 to 64 points. And a higher score indicates a more severe withdrawal experience. So patients at baseline had a SOS score of 31, which is indicative of severe withdrawal. That's 21 or higher. And those patients at those same patients at 76 hours, and this is nice because we have a complete data set, all 30 patients were here and still able to report their scores. They actually lowered their SOS score to 14. Meaning that they were essentially in moderate withdrawal. And this is when, typically you'd see withdrawal be the worst. Just for comparison, this is very similar to the drop that you see in methadone trials when patients are detoxing via methadone. So as a non-opiate medication, again, very encouraging results and statistically significant. So now we're going to transition to the second study. Before we do that, I do want to just kind of sum up the study 1 results. Patients had at 12 months had a decrease in drug use. For those who followed up, patients also saw their SOS scored lower, meaning that they had less withdrawal symptoms at 76 hours. And they even showed some evidence that the psychedelic component may have benefited patients and had them use less opiates. So now starting study 2, the New Zealand study, again, it's published by Noller et al. And had a very similar regimen. They use capsules in this study where the other one just used a powder, but essentially the same thing. They went through that test dose, then a larger dose, and then smaller doses as needed. Baseline characteristics for this study, patients were on average around 38 years of age. About half were female, all were Caucasian as it was in New Zealand. And patients had just under 5 average treatments for substance abuse. And what's different in this study is that the majority of these patients were on methadone rather than IV heroin. So this is a less severe patient population who would probably receive higher quality treatment, is my guess. 20 patients inquired about enrollment, 14 completed treatment, but very unfortunately, 1 patient actually died during Ibogaine treatment on the day that they were given Ibogaine in the study. This actually received some press because probably because this was part of a study in Ibogaine. 2 investigations were started into this death of this patient, and the treatment provider was determined as being in breach of their duty of care. However, there was no medical explanation for the death. This is just conjecture, but again, you have methadone, you have patients who are kind of sick in general a lot of times in these type of studies, and there's a lot of potential for QT prolongation when you introduce Ibogaine. So again, this just reiterates how important it is to provide the most safety possible for patients when they're in this vulnerable position. The outcome measures in the New Zealand study, 2 of the 3 were the same. They had the ASI, which I've put on the left there. In the lower right are SOS scores. We're going to go over both of those. And on the upper right-hand side, this study also looked at depression via the Beck Depression Inventory. So we'll take a look at those results as well. So in terms of ASI, there were 8 patients who were 8 out of the 14 patients followed up at 12 months. Those patients, we'll start with the drug row first, had a mean ASI score of 0.32, and at 12 months of follow-up, that had dropped to 0.06. So again, a statistically significant drop and certainly a clinically meaningful one. In terms of medical findings, I just kind of found this interesting and had to do a little bit of research to understand this. Patients went from 0 at baseline, meaning they had no medical disorders, they weren't reporting any on this scale. And then at the end of 12 months, we're actually at 0.34, meaning they kind of needed treatment. But what happens oftentimes, so I found out in opiate studies, is that patients have a lot of underlying sickness. I mean, it can be anything from fractured ribs to a rotting tooth that they just didn't know about. The opiates were covering them up. They just weren't, those other problems weren't the priority. You stop taking opiates and a lot of things come forward, and you start seeking treatment for things that you've either put off or didn't even know you had. So that's probably the case here. Looking at changes in depression, 14 patients were interviewed at baseline, and they had a mean score of 22, indicating moderate depression. And at 12 months, of the 11 patients who followed up, that had actually dropped to 4.4, which means patients had no or minimal depression. And I bet this had a lot to do with ending opiates. I can't say for sure whether it had to do with the Ibogaine trip or the experience specifically, but I think this is really interesting information. And do keep in mind that Ibogaine is kind of known for putting patients in a depression in the week or 2 or 3 after it's taken. But I've also heard anecdotally that it can actually elevate you as time goes on. So that might be what's at play here. SOS scores were very similar to that seen in study 1. Patients started in severe withdrawal, and by between 42 and 84 hours, patients were in mild withdrawal. So again, very similar results to study 1. This study also incorporated drug screening, and at 12 months, a total of 6 patients tested negative out of 8 who were tested. So 75% of the 8 patients that were available for testing were negative. To put a little caution here, opiates typically have between a 1 and 4 day detection window. So, you can't be absolutely sure that these patients weren't taking opiates, but it means they were probably taking them less. Maybe they weren't taking them at all. And I think, again, it's encouraging. So sorry for all the text on this screen, but I had a lot I wanted to get out on the final 2 slides. I think you got to look at this in context. These studies provide early evidence of treatment effect in a prospective study. So it's really encouraging, but I want to say it's really potential for efficacy, and we need to study it further. There are a lot of limitations to these studies, and we'll get to those in a second, but what the really positive signs for Ibogaine in these is that we certainly saw attenuation of withdrawal in terms of SOS scores. We saw sustained reduction in drug craving and use in some patients, with about 20% of patients not using opiates at all, at least in terms of self-reports at 12 months. Limitations of these studies, really small numbers. It was not controlled, nor was it blinded. And safety was considered beyond the scope of this non-interventional study, and that's the author's wording that they used. Very loose protocols. You would see much stricter guidelines to help control for what type of patients are in studies, had this been run by a pharmaceutical company. And then I think this can't be ignored, but there's always a bias toward patients who are seeking care themselves, especially if they've traveled from outside of the country, say from the US to Mexico, to seek treatment. These are highly motivated patients versus patients that are typically in large pharmaceutical trials who are actually being paid for their own trial participation. So as a pharmacist, if a patient or friend came to me, who might I think Ibogaine would be appropriate for? And I'm not gonna hold back. I think I would be very, very hesitant to suggest Ibogaine therapy to someone. But if someone came to me and they had done a lot of research, I would tell them this. This should be reserved for those who clearly understand the serious risks of therapy up to and including death. I think that you should research your study center thoroughly, make sure they have every available safety protocol, as well as an HCP on site and access to a hospital close by. I think that you should have already failed other evidence-based detox, whether that's Suboxone or methadone, and really gone through the other things that have been shown and are known to work. And then finally, are you familiar and comfortable with a 20-hour nauseating psychedelic trip? I think that could be mentally taxing for people who are in a vulnerable spot. Maybe they've never had a trip before. I think it's certainly something that needs to be considered. So last slide, guys. Much work needs to be done in terms of Ibogaine therapy. I think a true pharmacologic profile needs to be established. We need to understand its mechanism. That would also help us to develop more medications that could help with opiate withdrawal. We need placebo-controlled trials. And I think if you're not going to have any of that, you at least need a safety regimen established by experts in the field. We have to think about whether stepwise therapy might be most effective. Now, we've talked about how methadone has its own problems, but what if we had a Suboxone bridge? So patients went from IV heroin to Suboxone, and then we put them on Ibogaine for detox or 18-MC. Might we have better results that way? For those, and the reason I say that, for those patients in the New Zealand study, they did better than the patients in the Mexico study, and they were less severe opiate patients. There is a lack of profit motive, which makes it hard to do any research on this. It's been around a long time, and probably you get 5 years max on patent protection. And so what this tells me is really the future of Ibogaine may be in Ibogaine derivatives such as 18-MC, pictured at the bottom right. You know, this is a non-psychoactive, so you're more likely to get through regulatory agencies such as the FDA. It's less cardio and neurotoxic, has a more established pharmacologic profile, and most likely it's going to have less drug-drug interactions. So guys, I'd like to thank everyone for your time here tonight. I did find a really interesting podcast when I was doing research for this presentation on Howard Lotsoff and 18-MC. I'd definitely recommend that you check it out. I'd like to thank everybody for being here tonight and open up the floor for any questions you might have. Thanks so much.
Awesome. Thank you so much, Ryan. That was a really awesome presentation, and definitely on Ibogaine is not something that you hear about as much. So it was really great to hear like an evidence-based talk on it. So we'll get right into questions. This first one here is from Michael, and he's asking, do ancient cultures that use Ibogaine have any comment on the potential deadliness? I would imagine over many years they would have observed this and possibly have some idea of how to prevent it.
That's interesting. You know, I didn't come across a lot of material for, you know, for how ancient cultures used it other than what I alluded to. And I haven't seen anything in terms of death. You know, I think that Ibogaine is probably not the only agent responsible for death in these patients. I think these might be medically compromised patients to begin with. And also if they're on other QT prolongation medications known to prolong QT, that's probably a big part of the problem.
Awesome. Next question also from Michael is, what are the benefits of the dosing style? What has led them to consistently use such a complex routine?
That's a great question. So there is, I don't want to call it a committee, that's probably too formal. There has been some communication between different clinics that give Ibogaine, and they have kind of established this kind of quasi formula for giving it. And it seems that not every clinic actually follows that, but a lot of them do. And I think it's just through experience that they've kind of developed this. So they are following some type of protocol, but it's certainly up to the purview of the administrator to kind of do what they want and what they think's best for the patient. And a good example is the booster doses at the end. They just do it until they feel like you're ready to stop taking it. You know, what does that mean? As an evidence-based pharmacist, that's kind of hard for me to buy into, but you know, that's what it is, and that's where it's coming from.
Very interesting. Next question here is from Leo, and I think this is regarding the New Zealand study. He said on the ASI results, N was 8, but I thought it was 15 ? The people that were enrolled in the study, why were some patients not in the data, or did I misread something?
So the data for these studies I felt was a bit incomplete. So first of all, keeping up with patients 1 year after a study with limited monetary rewards is incredibly difficult, but especially in patients with long-term opiate use. So I understand why about half the patients are missing from the data. That's the reason. You know, I looked at some interviews when I was preparing for this presentation of the authors. They did everything they could to contact these patients, but both the patient and the person they had enrolled. Hard to keep patients in a trial like this. I think they were paying them like $10 per interview to keep up with it. And it might have been partly by design because I don't think they were performing the ASI at every time interval for every patient as well. So there is a lot of missing data. They also don't give really great explanations for the missing data in the actual article. And if you guys are interested in this, I highly recommend reading the articles that these two published. It's on the MAPS website, so you can go check it out for yourself. But yeah, unfortunately, there is a lot of missing data here.
But yeah, were they still having significant withdrawal symptoms? And was their methadone dose held prior to initiating the Ibogaine treatment?
So most patients, at least, so in the Mexico study, there was less methadone patients, and they converted everybody to oxycodone in the time right before they were given Ibogaine and the 2 or 3 days before. That's where that 90 to 270 milligrams per day comes into play of oxycodone. In the methadone, in the New Zealand study, they were less clear about how they did this. It seemed as though they left them on methadone up until they were treated, although there was less details about this that I recall anyway, and I think there was less in the paper.
All right. Next question from Michael. Do you have any insights on the DemRx pursuing Ibogaine despite the lack of patient / profit motive? MAPS is doing so as well, but they're nonprofit.
No, I don't even know. The only thing I know of that's ongoing for Ibogaine, I think there's a study out of Brazil for Ibogaine treatment for those who have an alcohol addiction. I don't know of any other ongoing studies. So that, it's news to me. It'd be interesting to look at. So the way that this works, and I'm certainly not an expert in this, but if you come up with a new indication for an old molecule, you can get up to 5 years usually, and this is for the US FDA, which I think they will probably never allow Ibogaine, to be honest, partly due to safety and the trip. But you can get 5 years of exclusivity, and that's like your only time to make a profit. I don't know if they'd have to crunch the numbers to see if it's worth it. I'm not sure if it would be for a for-profit drug company.
Gotcha.
My guess is no.
Mm-hmm. Next question from Claire, asking, what does the Ibogaine family look like in terms of the plantae?
Oh yeah, so that's on slide 1. I think there's a way to, there we go. So this is what it looks like on the left-hand side of the slide. It's a shrub. It's native to West Africa, and it's got like this orange-looking, I don't know if it's a fruit or something hanging down with it, but the actual medicine comes from the root bark. So it's like a powder, like a white powder, I believe.
Perfect. And last question here before we move on from Court, and they're asking, were there any lateral benefits reported, such as reduction in chronic pain, improved digestion, improved balance, reductions in vertigo, etc.?
I didn't see any of that. Now, if you were to be able to dive into the ASI that the patients reported on, you might be able to find some of those. The only thing I really saw was the Beck Depression Index that looked like a lateral benefit. But if you look at some of those findings in the ASI, there's something going on there because, for example, they're doing a lot better with their family. They are at least in the New Zealand study, they are addressing medical needs that were probably not addressed prior to this treatment. So you'd have to kind of look into that, and that's beyond even what was published in the study for sure. But I bet the study authors would have something to say on that.
Perfect. All right, so unfortunately we do have to move on as we do have to get to the next presentation, but thank you so much everyone for asking questions and contributing to the dialogue. And most importantly, thank you so much for Ryan for sharing his wisdom with us.
Thanks, guys.
I'll pass it over to Leo.